So thank you everyone for making the time to come out and hear a little bit about adaptive mentoring and how we can build compassionate primary care through this process. Before I get started, I also wanted to thank all of my colleagues at Pain BC for being so gracious and wonderful in inviting me to come in and share a little bit of what I've learned over the last few years. So as a quick introduction, I'm a family physician with a focused practice in chronic pain working here in Ottawa, Ontario. I work both in the academic settings with the Ottawa Hospital as well as in the community. And the other hat that I wear is that over the last 10 years, I've been studying and helping to build continuing professional development programs, including mentorship networks, both here in Ontario and also supporting program development in the East Coast and Nova Scotia in particular. And so what I'm hoping to do over the next hour or so is share with all of you a little bit of what I've learned through my journey in building these networks and the kind of impacts they can have. Okay, so we'll keep moving along. So the next slide that we'll go to here is a little bit about our objectives. So what are we going to try to accomplish in our session today? And so the first thing we're going to try and do is to describe the key elements of adaptive mentoring as a concept. The second objective is to try and help us identify examples of the application of adaptive mentoring in the environments here in Canada in specific. And then the last objective is really to try and help describe what are the impacts of these types of mentoring programs on us as providers, but also on patients, as well as the system as a whole. So before we get going, I think it's always important to walk through some disclosures. So as you can see here, I've received honoraria and fees for service in my roles that I've played with the Ontario College of Family Physicians, as well as the Centre for Effective Practice. So what might potentially mitigate a bias that may be there? Well, it's important to keep in mind that both of these organizations and the work that I did for them were all in the envelope of being nonprofit in their nature. So with that out of the way, we'll move on to, I think, what are probably an important piece, which is really setting the background. So really we should think about, well, why are we talking about capacity building? And why are we talking about an intervention to build capacity of primary care? So when we look at some of the reports that have come out, whether it's the Canadian Pain Task Force reports or Canadian Mental Health Commission reports that have come out over the last 5 years, we clearly are identifying that there is an issue around access to care for patients in the areas of mental health, substance use disorders, and chronic pain. And this issue is present throughout the country, whether you're in BC or Ontario or Nova Scotia or Manitoba, wherever it may be. This is a recurring thematic issue. And when we look at these reports, what we're learning is that the issues are complex. They're not simple. And many of them are related to capacity, whether it's at the tertiary or specialist level, or even at the primary care level. Stigma is prevalent throughout the system, and this creates issues around access as well. And of course, the system itself is not well designed to address issues around social determinants of health. And all of these combined together create some of the access issues that our patients and we are experiencing. So one of the things we also see from these reports are solutions that are put forward. And many of these solutions think about or focus on education of healthcare providers with an eye towards building capacity, and especially at the primary care level. And so if we're thinking about building capacity at that primary care level, it's also an opportunity perhaps for us to think about how do we focus on a capacity building that has a compassionate care focus. And that's important because it helps to address some of those issues of stigma that we've identified around access. Now, the other piece about developing primary care capacity is that it fits with what we understand are best practices around trying to deliver care for our patients in their patient medical home or neighborhood. So what does that mean? Well, let's think about a patient or an individual who's trying to seek care living in a rural or remote area. Instead of having to travel to an urban center for care, if they can access high quality care close to home within their primary care teams, that would create, hopefully, improved experiences, reduce travel, and put less burden on our patients. So with this in mind, what we're going to try to explore for the rest of the session today is what is adaptive mentoring, and really how can we use it to build a primary care capacity that we need. So over the next few slides, what we're going to explore are some conceptual ideas and frameworks. And really, we're going to explore this to really get a sense around, well, what is this idea of adaptive mentoring? So let's start with this, I think, most important question. Well, what is mentoring? So when we hear this term, I think it's a familiar one to most of us. And it often evokes ideas of a guide or an advisor, someone who's wizened, has experience, and who's then looking to partake or share that experience and information with someone who is new and fresh to the area or the field. When we look at the literature around mentorship, what we find is that it is widely used in a variety of different fields, ranging from medicine to nursing, business, engineering, and education. And what we find within these fields is an enormous broad range of uses. So for example, in medicine and nursing, mentoring is often used to help shape and build people's careers, particularly around academics and research. Whereas in the business fields, what we see is that mentoring is often employed as a tool within organizations to retain and propagate their organizational culture. In the field of education, mentoring is often used to bring people in, novel teachers, new teachers, not just to help them learn about how to be teachers, but to bring them into the community, to embrace them into the community. So as you can see, a real wide range of how mentorship is used. Now again, when we try to look at the literature a little further, we see a broad set of uses, and we also see that there is no singular definition of mentorship. In fact, when we look at it, mentorship is often associated with some of the terms on this slide, like communities of practice, preceptors, role models, and coaches. And this conceptual ambiguity is oftentimes because mentorship does share features with each one of these concepts. So for example, a preceptor endeavors to impart knowledge and share with the student or the learner, much like a mentor would. However, the difference is that a preceptor is expected to evaluate that learner, where a mentor is not. When we look at a role model, well, we do role model, we do model ourselves after our mentors. But the difference between a role model and a mentor is that a role model is typically an informal relationship where mentorship is far more formal. Coaching and mentoring also share a lot of similar facets and features, especially around guiding individuals towards achieving their goals. However, where they differ is that at its heart, and probably one of the most important features of mentorship, is that there's a bidirectionality of knowledge exchange and learning. Your mentor is also learning and also benefiting from that relationship with that mentee. So what is this concept of adaptive mentoring? Well, in this broad mix and sort of loose, fuzzy boundaries around mentorship, what we've strived to do is create a novel concept that really is around how do we apply mentorship to build compassionate primary care capacity around the areas of chronic pain, mental illness, and substance use disorders. At its heart, adaptive mentoring really is about growing communities that connect clinical experts with primary care providers to support the transfer of clinical knowledge and support clinician resiliency. So we're looking to create communities that are connected to each other. So to try and address some of the ambiguity around what mentorship is, what we've proposed are 3 key features of adaptive mentoring. And I'll take a few moments to try and walk us through some of that. So the first feature is that adaptive mentoring is a mentoring that adapts to the needs of the mentee. Well, what do we mean by that, and why is that important? Well, when we think about us as primary care providers, what we understand is, first of all, it is a heterogeneous group of individuals with an equally heterogeneous set of needs around learning. Our learning changes both in time and in situation and context. How we need to learn and the ways we need to learn are always dynamic and changing. So in order to be able to support that, we have to have some adaptability in how we engage and support primary care learning needs. So how can mentorship be adapted? And so what we're going to talk about next is adaptability in 2 dimensions. The first is what we call the mentoring form. So how you engage with your mentor can occur in a variety of different fashions. So typically, we're used to engaging with mentors in a one-to-one fashion. You have one mentee and one mentor, and you connect with each other and have conversations. But we can also have group mentoring, where you can have multiple mentees and multiple mentors interacting and having conversations together. And of course, we can also have peer mentorship, where our colleagues, our peers, can also help to inform, educate, and teach us. So that's one dimension in which we can adapt mentorship. The second dimension in which we can adapt mentorship is around the environments in which mentorship takes place. We know that mentorship can effectively happen in person, by email, telephone, and video conferencing, to name a few. In fact, mentorship can even take place on text messaging and online forums. So what we want to look at when we think about adaptive mentoring programs is mentorship that flexes to meet the needs of that mentee, both in terms of the form of mentorship, but also the environment. So continuing on with those key features, the second feature of adaptive mentoring is that it is rooted in creating what we call compassionate communities that are present for both the mentees and the mentor. And what do we mean by compassionate communities? Well, we're talking about environments that are safe and non-judgmental spaces, a space where we can come and share our lack of knowledge, our fears and worries about how we are helping our patients, or where we may be making mistakes, or where we're worried that we might be making mistakes. And in turn, not be judged for that, but instead work to help us understand and learn better. And we know that these kind of spaces help to nourish the resiliency of clinicians. So, but why is that important? Well, if we can improve our clinician resiliency, we know that it's going to improve our focus on care that is compassionate for our patients. And we also know that we're more likely to stay engaged to be able to provide and support our communities where we live. Now, the third feature of adaptive mentoring that is key is really around the bidirectionality of it. So that means, again, that the mentor and the mentee are both benefiting and learning in mentorship. Now, we know as mentees, mentorship can have enormous impacts on your knowledge, your competence, your clinical skills, your confidence. It can have impacts on your clinical behavior. It can have impacts on your career progression and your communication skills. So a lot of impacts that happen at the mentee level. And when we look at the literature around mentors, we're seeing almost a similar or a mirror effect. We're hearing that mentors themselves are improving their knowledge base. They're learning more about what it means to help patients in the community. They understand better the limitations of the community. Mentors, in turn, are more likely to have improved career trajectories, improved communication skills, and their resiliency is also improved, along with career satisfaction in being able to connect and engage with their colleagues. So now that we've taken a few moments to just understand those concepts of mentorship and really what do we mean conceptually about adaptive mentoring and why it's important, well, let's start to think about, well, what can adaptive mentoring do to help us build our capacity? Well, what we know is that adaptive mentoring, from the examples that are there in the environment, is that it tries to build capacity by addressing the clinical struggles that a provider may face when they're looking for timely access to support from specialists. So being able to connect with a mentor and be able to talk to them within an hour or 4 hours or 24 hours is an incredible support. We know that adaptive mentoring can build capacity by breaking down those barriers and those silos that exist between our tertiary colleagues and our community colleagues. That connection, that interprofessional connection that takes place as well is important. Lastly, adaptive mentoring can also help us build capacity by providing a longitudinal support. And this longitudinal support is important and is well aligned with providing complex care on an ongoing basis in the primary care community. Mentorship offers us an opportunity beyond just a simple consultation. A consultation that may be a one-off doesn't really afford for there to be dialogue to adjust and tweak management and treatment as we go along. It doesn't allow for that conversation to take place over time and accordingly help to provide additional support to our providers. So having started to get through some of the conceptual ideas, let's maybe try to get a little more concrete. And so over the next couple of slides, what I'm going to do is take the opportunity to describe to you what are typical mentoring formats or structures that we see in the programs that are there in Canada at this time. So on this slide, what you can see is at the center of it is an individual, might be you, might be a mentee. And that mentee, as you can see, is going to be connected to mentors who may be experts in mental health, chronic pain, or substance use disorders. Now, typically when you're connected to that mentor is identified or selected as someone who is within the same region as you. So I don't think it makes a whole lot of sense to connect an individual in Victoria with a mentor in Toronto, but rather someone a little bit closer makes a lot more sense. So once you're connected with that mentor, you have the opportunity as the mentee to reach out to them on demand. So when you need it, you reach out to your mentor with a question. Maybe, how do I rotate to a new antidepressant? Might be the question you pose. Now, once you've had that opportunity to reach out, your mentors typically will try to follow back up with you within about 48 hours. So again, a very short turnaround time. But in most cases, it's a lot shorter than 48 hours. Many mentors will respond back within a couple of hours. Now, how you reach out to your mentor, again, can be multiple, adaptable in different formats. You could reach out by email, by telephone, text message, whatever you and your mentors may agree to. And so this is how we connect mentees and mentors together, how we allow for them to adapt the environments that communication can happen from on a one-to-one basis. So again, going along with that adaptive theme and now thinking about, well, what could a group mentorship look like? Well, as you can see here, we basically look to bring together multiple mentors and mentees together, all within the same region, again, keeping a regional focus to this. Now, as a group, what you'll identify or what we see is that mentors drive group meetings. They're the ones who'll help organize it and have it with some regularity. Where the one-to-one meetings are often driven by the mentee. It's based on their need, their questions that are driving them at that time. Group mentorship oftentimes includes some opportunities to focus on some didactic discussions, so general topics, but also has the opportunity to dive into some rich case discussions. Now, as you can see, again, we have that adaptability in environment. So we know that group mentorship can take place by email, by telephone, video conferencing, and even face-to-face meetings. Now, this group mentorship can become a very powerful piece because now you combine together that group and peer mentorship. And again, these groups can go on for long periods of time. Here in Ottawa, we had a mental health group that had been active for almost 15 years together. And one of the things that we heard from this group is about how they were able to support one of their colleagues to provide care around a complex mental health issue. And they were able to work with that colleague to support that patient over a 5-year arc to try and make sure that patient received care in their home, in their patient medical home, and reduce the number of times they had to go to the emergency department or be admitted to hospital. So again, that longitudinality is, I think, something that's really unique to mentorship. And again, is really at the core of building communities. And so the last piece I wanted to talk about, what can an adaptive mentorship look like, is large group mentoring. And really what this is bringing together all of these small regional groups, perhaps across a province, into a larger group. And what you can see here is that these large groups start to resemble a little bit of a community of practice. In this large space, which often exists in online messaging forums, We can have mentors and mentees posting questions about clinical challenges that are there, talking about resources, sharing stories around advocacy. So all of these can be supported within these larger spaces. Here in Ontario, at one point, we had groups, our spaces had grown to about 500 people. And the power of this was in the speed with which someone could get an answer and the variety of perspectives one got on an answer. So for an example, what we found in Ontario within our addictions and pain group was that if someone posted a question, 70% of the time they got a response back within an hour. And the other 30% had a response back within 2 days. The other part that we saw was, again, that breadth of response, which really helps us start to understand, well, what is the clinical standard of practice in trying to provide care in complex situations? And in a way, that can oftentimes be reassuring to us when we're facing those anxieties and fears around what to do next. So having walked through, I think, some of those conceptual ideas and trying to make a little bit more concrete what we mean by adaptive mentoring, in the next set of slides, what we're going to try and do is really think about, well, where and how, where has this been applied? Where are some examples of mentorship? And then start to look at some of the data that's out there around what can mentorship do for us as providers, our patients, and at a system level. So in terms of examples of adaptive mentoring networks, I think let's start with the Collaborative Mental Health Network and the Medical Mentoring for Addictions and Pain Network here in Ontario. Now, the Mental Health Network was established back in 2001, and the Addictions and Pain Network in 2007 and 8. Both programs were in existence until just early this year, at which point there was some funding challenges, and so those two programs have now been closed at this time. These programs based in Ontario focused on family physicians, and prior to closing, they were at about 1,000 individuals, 1,000 family physicians that were part of these networks. These programs together were looking at the clinical topic areas around chronic pain, mental health, and addictions. The Atlantic Mentorship Network, Pain and Addiction, is a program that was launched in 2007 based out of Nova Scotia. Importantly, this program was had an interdisciplinary focus, which means that they included nurses, nurse practitioners, pharmacists, physicians, social workers, to name a few. Currently, their membership stands at roughly 150 individuals across Nova Scotia, and they focus on the clinical topic areas of chronic pain and addictions. And the last example I'll provide here in Canada is the Collaborative Mentorship Network, which was established in 2018, based in Alberta. Its focus is on family physicians and the topic areas around addictions and chronic pain. Now, when we look at these different programs across the country, most of them share a very similar format and framework of how we organize mentors in that one-to-one format, group format, and even that large group format that we talked about. So let's now start to look at some of the data. So over the next few slides, the data that I'll be presenting has been drawn from the program evaluations for the Ontario networks and the Nova Scotia networks. Now, the sources of data from these evaluations is really of two forms. The first is participant surveys, and the second is participant interviews, more of a qualitative-based research. Now, as we're looking at this and thinking about the impacts of these programs, we really want to think about some of the data limitations. Now, we know that most of this is self-report, telling us, again, what do our participants and the providers feel, believe, and experience is happening as a difference of participating in these programs. It's also important to keep in mind that in terms of the quantitative surveys, the lowest bar that we had was a 50% response rate, which is still pretty reasonable. But some of the other surveys were able to achieve up to 80%. But nonetheless, we're looking at a range of about 50 to 80% in terms of response rates. And then, of course, when we talk about data at a patient and system level, a lot of this is, again, reflections, qualitative, and self-report that's coming from our members. And this is definitely an area that we would look to try and broaden over time. So let's start with, I think, the most important, one of the key questions to start with, which is who usually joins these programs? Well, when we think about it from a geographical perspective, what we see is that the distribution of membership really ranges from that inner city urban environments all the way to geographically isolated and remote spaces. So the key thing to keep in mind is that these mentorship networks have a broad appeal to clinicians in all sorts of jurisdictions. When you look at the composition, what we see is that rural and remote participants compose anywhere between 12%, which we saw in the mental health group in Ontario, to up to 40%, which is present in the Nova Scotia groups. Now, in terms of where clinicians are in their stage of career, again, there seemed to be, when you looked at all the different programs, a broad representation. You have people who are joining who are new early in their careers to individuals who are closing in on those retirement timeframes. When we look at the programs in Ontario, what we did see was there was a large skew towards older clinicians, those who are older, further along in their practices. Where in Nova Scotia, what we did see was that close to 30% of individuals, a far larger proportion than we saw in Ontario, were earlier on in their careers. And I'm not quite sure how to explain that difference. Perhaps some of this was in how there was outreach to recruit people, but I suspect part of it might be also due to the differences where Nova Scotia focuses on a more interdisciplinary audience than Ontario did. Now, in terms of the practice environment that we're looking at for participants, what we did find is that this skewed significantly towards a community-based practice. So about anywhere between 40 to 60% of the participants in the programs in Nova Scotia to Ontario skewed towards the community. And that's a really important piece, I think, especially from a continuing professional development perspective. Now, that audience is a tough audience to connect with. Ones that we can't easily connect with to try and help them improve and increase their knowledge base. But we did find that mentorship networks seem to be serving this community fairly well. When we look at the types of providers that were participating in this program, and Nova Scotians in particular, what we saw was an even split between the physicians and all other providers that were part of the program. And so the last point I'll highlight on this slide is around how long people were spending in the networks. So when they joined these networks, well, how long did they hang around for? How long were they a part of this program for? And so what we saw across the programs, Nova Scotia and Ontario included, was that over 50% of people were in these for 3 or more years. And when you looked at a program like the mental health one here in Ontario, you were looking at over 50% were there for 8 or more years. And so I think what we're seeing is a couple of things. One, these programs were able to deliver on the longitudinal component of that mentorship piece that we're talking about. And of course, I think it's a signal for communities being formed that this wasn't just about learning and leaving with a piece of information, but you joined a community and you continued to work with each other and support each other over the years. And so there was this traction that was obviously present in these rather stunning numbers around how long people were spending within these programs. So in this slide, we're going to take a few moments just to sort of reflect on what are the impacts at a provider level that we're seeing from the program evaluation data. So as you can see at that first bullet, that over 90% of the individuals who are participating identified that their knowledge had improved as a product of being part of these programs. Over 80% of individuals identified that their competence or their clinical skills had advanced in some fashion, regardless of whether we're talking about mental health, chronic pain, or substance use disorders. Over 85% of them identified that they felt more confident in being able to support their patients. They weren't necessarily as afraid or nervous about making a bad decision. Over 70% of members identified, especially in the Ontario context, that because of being a part of these programs, they felt less isolated in their practice. and at times less stressed. And in Nova Scotia, what we saw was that 78% of individuals identified that this improved their interprofessional collaborations. And that goes back to that idea of breaking down silos. Like, how do we build communities together? So in this slide, I wanted to reflect on a few findings as it pertains to impact at a patient level. Now in Nova Scotia, what we've heard is that over 73% of our providers determined that this improved their compassionate interactions with their patients. And in Ontario, what we heard is that over 70% of people participating felt that they, by being a part of these networks, that they could have a positive impact on their patients' quality of life. Well, what does that mean? It sounds very abstract, very nebulous. So to help make this a little more concrete, I'm going to read this little quote here from one of our members from the qualitative parts of our surveys. So pain specialist referral in Northwest Ontario took 2+ years. However, getting my questions answered by my mentors in the program helped me to manage a very complicated patient, and he's better for it today. And that goes back to some of those ideas we're talking about. So instead of a patient waiting for 2 years on a wait list, by having that mentorship support, we can create access, faster times by which we can connect with our patients, as well as being able to serve them in the communities that they live in and not always having to send them to a tertiary care center. So I wanted to take a moment just to dive a little bit more into this notions of compassion and mentoring. So I was very fortunate to be an AMX Phoenix Fellow in Compassionate Care between the years of 2017 to 2019. And as a product of that fellowship, I had an opportunity to work on a few qualitative studies. And I'm going to talk a little bit about one of those studies here now. So this study, we took the opportunity to interview individuals in the Ontario programs, both in the mental health and addictions and pain programs, to really kind of dive down into how does mentoring affect compassionate care. And what we learned was that there seemed to be 3 key areas that this seemed to be happening, or three key methods by which mentoring was supporting or building compassionate care. The first was that concept and idea of role modeling. And what that means is that our mentees are watching their mentors, watching their peers, and are learning from them and modeling their behavior like them, normalizing their behavior. And what they learned was motivation. Being with individuals who were motivated to focus on compassionate care, in turn motivated their mentees to be more compassionate. Learning, watching, and hearing about how mentors and their peers focused on sympathy and empathy in their discussions about working and supporting our patients motivated our mentees to do the same. And so motivation became a very clear and important piece of this. The second mechanism by which mentoring was able to support compassion was around skills and skills transference, and specifically around the areas of sensitivity, learning how to take a trauma-informed approach, learning the skills and the language of communicating sensitively. And that's learned through the conversations, the dialogues that take place in the mentorship environment. And the last is about building a safe space. And so mentorship was developing these safe spaces. And what does that mean? Why was that important? Well, we know in compassion, distress tolerance of us as providers is important. We have to learn to be able to tolerate the distress that we're seeing in our patients, in ourselves to manage the distress that we are feeling when our patients are suffering and that we can't always help them in the ways that they need immediately. So learning how to manage that distress is something that happens within these safe spaces. Having these safe spaces and these compassionate spaces for providers helped them manage their own distress that they were seeing. And in these safe spaces, mentors and mentees learn about what it meant to work and exist in non-judgmental spaces. And in turn, how do you translate that to your patients to be non-judgmental with them? And so through all of these mechanisms, we can see how mentorship builds compassion. And so I felt that this quote symbolizes some of that, which goes on to say, again, from one of the members of the Ontario program states, I feel more willing to tackle complex issues and care for patients with complex issues when I have the support of the mental health network. And really what that speaks to is that motivation, which I think is probably one of the most important things we can have and we can build when we're trying to focus on compassionate care. So in this final slide around data, what we're looking at here is impact at a system level. And so when we look at this set of data, what we heard back was that in the Ontario networks, individuals were saying they saw a change in their behavior where they were seeing more patients who were living and suffering with chronic pain, mental health, and substance use disorders. And close to 63% of members identified that this was true. What we also found within the Ontario context and Nova Scotia context is that both providers from all of these programs were seeing a wider range of patients. So it wasn't just seeing more, but they were also seeing more complex patients in all of these three clinical areas. And that was about 70% of individuals. In the Ontario context, what we saw was by participating in these programs, 31% of individuals identified that they were reducing the number of consults that were going out. So trying to alleviate some of that pressure, that capacity issue at the tertiary care level. Because at the end of the day, if we expect tertiary care to take over and to manage all mental health, all chronic pain, all substance use disorders, I don't think that's a feasible option or a sustainable option for the system. And the last piece is we see that supporting colleagues is reported by over 70% of individuals in both the Ontario and the Nova Scotia programs. So again, what does that mean? Reaching out, supporting your colleagues, whether it's a mentor or mentee, or even supporting those people who aren't part of a program. You may be in a practice working with someone else, but you reach out and you say, hey, you know what? I learned this from my mentor. Here's something I suggested we could do. And so we were seeing that there was this sort of an effect of bleeding of this knowledge outside of the mentors and mentees to the larger community at hand. So I thought this was a nice quote to be able to share around how access could be changed because of mentorship. And so this quote again from one of our mentees goes on to state, well, because of the mental health network, I'm able to provide mental health treatment and guidance to my patients, especially patients who are low income and can't afford psychologists or maybe can't be seen by psychiatry. So having kind of walked through some of these conceptual ideas of mentorship, what it looks like, how it's being applied, and what kind of impacts it's having, I thought it'd be valuable to just take a few moments to sort of think about, well, what have we seen, what have we heard, and where do we go from here? So we learned about, I'm hoping we learned about mentoring, and more specifically, adaptive mentoring. The concepts that are out there, some of the ambiguity that's there, but more importantly, that we have this concept of adaptive mentoring that focuses on how do we build mentorship that can change and meet the needs of our mentees? How do we build mentorship that values the impact on both the mentor and the mentee? And how do we build a mentoring program that builds safe, compassionate, supportive environments that really are a lot more, that are more than about just simply knowledge translation. It's also about resiliency. Now we learned a little bit about how adaptive mentoring networks and programs can address access and capacity, and we saw a little bit about from the data. But I think it's really important to keep in mind that I'm not advocating for adaptive mentoring to be the only solution to capacity building. I think we have to think of adaptive mentoring as one of a basket of solutions that needs to be there to address the heterogeneous needs of primary care providers. It can't be the only thing, but we can make sure that it can be one thing that works with a multitude of interventions that are out there, like Project Echoes, like e-consults, like academic detailing, to name a few. What we saw today, and I hope what you learned a little bit about, is multiple large-scale applications of adaptive mentoring. And what we saw was that these programs could be scaled, and we saw the Ontario program scale up to almost 1,000 members. But I still think there's a lot to be learned about trying to scale that even further to provide even more access at a provincial level. One of the things I think we can even take away from this is that we saw these programs operational for years and then decades at a time. And what I think that means is that these programs are sustainable. They're dependable, they're reliable. So individuals who can look to these programs know that they can be sustained over long periods of time. And because they can be sustained over long periods of time, that longitudinality can be supported. Now, in some of the evidence that we've talked about, I think what we're seeing is not a perfect body of evidence, but some growing evidence around how mentorship, adaptive mentorship, can build capacity. We saw how it can build knowledge, it can change individuals' behaviors, build resilience, and build compassion as well. But I do think there's a long way to go still around learning about how these programs can affect patient-level impacts. And this is where I would love to see additional research being conducted with our patients around how mentorship has affected them and their care. I think there's a lot to be done at a system level. Again, I would love to be able to see additional work being done in looking at large big data systems around healthcare systems. So looking at administrative data to help us understand what kind of an impact is mentorship having on the tertiary care system? What kind of an impact is it having on healthcare utilization in emergency departments and hospitalizations? I think we've just scratched the surface around what we're seeing around providers and the level of the impact on their resiliency with these programs. And I think longitudinal studies can help us learn a little bit more about how providers continue to be active supports in their communities because their resiliency is nourished. And I think there's a lot yet to be learned, of course, around that collegial support. How are we working with each other? And how does these enriched interprofessional interactions, how's that building us up as a community and optimizing the work that we do even further? So where to from here? So where are we going with this? What are some of our future directions? Well, my attention over the last few months has focused on some of these activities of building. And so over the last few months, I've been working with a number of individuals here in BC, as well as in Nova Scotia, Pain BC and the Atlantic Mentorship Network and the Center for Effective Practice, around looking to build a national collaborative that can help grow adaptive mentoring across the country. And we're looking to build programs in different provinces, specifically around in Newfoundland and Labrador, Prince Edward Island, New Brunswick, and British Columbia, to join the programs that are already there, existing currently in Canada. And all of these programs will keep at its heart an interdisciplinary focus, and will focus on the clinical areas of mental health, addictions, and of course, chronic pain. And to supplement this, we've also been working over the last few months to also build the Canadian Adaptive Mentoring Forum and space for interdisciplinary conversations and discussions to take place. And so this is still in its nascent phase, and we're hoping as we grow this, we can invite more people from across the country to join. And so with that, I'll stop and open it up for questions.
Thank you so much. That was a very compelling presentation. I was already convinced of the value of adaptive mentoring, as you know, but I always love hearing about it, and I just get renewed enthusiasm every time you talk about it. So we do have a couple of questions. I do, people are putting them in the chat. I'll read those out, but if I could ask everyone to put your questions in the Q&A, it's so I think you anticipated a couple of the questions. So there was a question about, well, what are we doing here in BC, which you have covered. Maybe you could just say a little bit about if sort of more practically speaking, the state of that proposal and when we would expect to hear hear back and get things going?
So, thank you for the question. And so, I have to say, I mean, the Pain BC group has been a phenomenal partners along with the Atlantic Mentorship Network in doing, I think, substantive groundwork in making sure that there is interest and that we have the right partners coming to the table to try and build these programs in each of the provinces. So I think the groundwork has been well laid, or is still a few pieces to be laid there. Right now, we're in the phase of applying for funding to receive federal, national level funding if we can, to be able to develop a set of pilot programs that we can run in each of these provinces. That would be, again, a pilot is for 4 or 5 years at a time, to see, can we build a rich program, a rich network? And then once we can establish that, then we have the seeds to continue the growth of those programs. So we're right now in that funding phase, and we're hoping to be able to get some information back in the next 6 to 8 months. So that way we can look at then transitioning into an implementation and growth phase from there.
And I would just also add that if people want to have discussions about that, we have done some consultation with the community, fairly extensive, but if people do want to have conversations about that, they're really welcome to reach out to me, and I would love to hear your thoughts and can bring forward any points from that discussion to the development team. Okay, thanks for that. Let me see here. Okay. Someone is asking, okay, so Katie is asking, and I think you sort of addressed this, but maybe you can just be a little more specific. So it seems like a lot of research on impact has focused, and she's wondering if the patient perspective has been evaluated, and you did say that you were hoping for more research in that area. Has any patient research been conducted?
Not yet. And this has been, a thorn in my side. Like, it's just something like I feel like, oh, this is like such a gaping hole. Like, we need to address this, right? We've put some proposals together. Again, we're looking for some funding on that to be able to execute that kind of research. But what I would say is that this would be like any new programs we are developing. So when we're looking for funding right now, this would be part of what I would hope would happen in the development of any new program, that we would reach out and start to do some really strong qualitative research. I think that's a very important place to start, and then we can translate that into a larger scale quantitative research at a patient level. But I think we need to do some very strong qualitative based work with our patients.
Yeah, makes sense. So it's in the pipeline pending funding.
Yes.
The second part of the question is, in the interdisciplinary models described, do providers / mentees get paired with mentors of the same and or different disciplines? As well, does it seem that there are less allied health professionals, it does seem that there are less allied health professionals involved in these mentorship models, and I'm wondering what your thoughts are on this.
Great question. I have to go back and look at the numbers in terms of looking at the ratios between physicians and allied health professionals. Yes, I think on the surface of it, if you look at the numbers, yeah, as a proportion, we're seeing fewer allied health professionals than physicians participating. And that's not intentional in any way. I think that is in some part, a lot of this ends up becoming about how we recruit people. So I think that's where we see some of those differences in terms of participation. With regards to your question around allied professionals, allied individual health professionals being mentors, there is no barrier to allied health professionals being a mentor. They can be mentors. They are mentors. I think in the Nova Scotia group, there are a couple. One of the programs I didn't talk about was that in Ontario, we did have a mentorship network that was focused on palliative care. And in that palliative care network, what we had was in each mentorship group, you had a physician, a nurse practitioner, and a pharmacist. So each group had 3 mentors from multiple disciplines always present in each of the programs. Now, that was a pilot network that we launched here in Ontario. So again, the model can work, and it did work in having allied individuals as mentors. And there's no limitation on that.
And I think the other part of the question was, so do allied mentors get paired with, or mentees get paired with a mentor of the same discipline, or is it more, as you described in the palliative network?
I think it's more open. I don't think we've necessarily said there has to be one-to-one. Now, again, I think there's room for further discovery. Like, I'm not going to say we know all the answers around how we have to build exactly the model for interprofessional mentorship. I think there is room to hear what people want. I think if there is a sense that, yes, we want some spaces where, a nurse is mentoring another nurse, or a pharmacist is mentoring another pharmacist. I think we have to hear if people want that and if that makes sense, and allow for some scope, right? Coming back to that sense, this is adaptable. We have to work to the needs of our mentees and have some adaptability in how we structure the mentorship.
And I've heard you, that's been a message that I've heard you say a lot of times, is the model has to adapt to the needs of the people that are using it, right? So it doesn't necessarily have to be one way or another. We just need to figure out what's needed, and then we need to create the system.
Right. And Jen, you've heard from our conversations, right? We adapt the model regionally too. It's not a one size fits all. What happens in Ontario isn't necessarily going to be what exactly happens in BC. We have to look at what the regional realities are. So we have to look at what is the needs of our patients, of our systems locally, and adapt the program accordingly.
Yeah, no, makes sense. So, theoretically, certainly there could be one-to-one pairing of the same disciplines. I know in our model, we proposed that as an option, but we also proposed small group interdisciplinary mentoring, where we would have, similar to the palliative model, we would have a number of different professions coming together, as you would see in team-based care, to discuss, whatever it was they needed to discuss.
Absolutely.
Interesting. Yeah. Okay. Katie, I hope that answers your question. Right in again. And this another question is, you had said that the Ontario network lost funding, and Katie's curious to hear what you thought contributed to this and what can be done to help fund these programs in the future.
Yeah, so I think a great question. I think part of that disruption in the funding at that time was COVID related. So it was just bad timing that we had a refunding request come up at just the right time, or just the wrong time, I should say. And that caused a disruption in funding. So there's still some fallout from that in terms of figuring out what to do next. I think ultimately when we're talking about these type of programs, the natural funding location tends to be a provincial level funder. And I think it's incredible to have that funding, and we're in each situation, it's amazing to be able to get the provincial funding. But I think to keep programs robust and stable, we need to look at probably multiple sources of funding. So again, is it only the provincial funder that is the individual, that is the group that we'd look at, the provincial ministries? Where else could we look at funding? So could organizations, professional organizations be part of the mix that goes in there? Could users, the people who are participating in these programs, could they also be part of the mix in terms of, not all of it, but a stream of income? So there needs to be some diversification in funding to be able to maintain stability over, again, decades.
Yeah, that's very sensible. We hope the funding returns to the Ontario network.
Absolutely, yes.
So much for joining us. And Dr. Radhakrishnan, we just so appreciate your time and hearing about the Adaptive Mentorship Network.
My pleasure. Thank you so much for having me, and
thanks everyone.
Such a wonderful audience. Thank you.
Thanks. See you next month. Bye-bye.